Good afternoon, everyone. My name is Jacinta Smith, and on behalf of the PCPCC and our Support and Alignment Network, I want to welcome you to our September National Briefing webinar. We have two special guests from HealthTeamWorks and Cigna Medical Group joining us today to share timely information on meaningful patient engagement and practice transformation and the strategies used to inform and improve progress toward the Quadruple Aim. If you have any questions or comments during the webinar, please feel free to type them into the chat box. We don't take audio questions, but we'll gladly answer the questions we do receive at the end of the presentation or during our office hours session after the webinar. This webinar will also be recorded and archived on our website for future reference. So we'll begin with our presentation with Nicole Diener from HealthTeamWorks. Nicole?
Hi, everybody, and welcome. Dan and I have been working together over the last few years, and we are delighted to be talking to you today about something we both believe in and feel passionate about, which is meaningful patient engagement and quality improvement at the practice and system level. Dan will introduce himself during his portion of the presentation. I'm Nicole Diener, Director of Training and Education at HealthTeamWorks, and I've been with HealthTeamWorks for about 8 years. HealthTeamWorks is a nonprofit collaborative based in Denver, Colorado. We've been in existence since 1996. For the last 10 years, we've been working with practices, physician groups, and integrated clinical networks on transformation and training activities that have resulted in measurable improvements. We're currently a practice transformation organization in Colorado, serving practices in the State Innovation Model, TCPI, and an AHRQ statewide program, Evidence Now Southwest, as well as completing the first round of the Comprehensive Primary Care Initiative. In 2011, the Institute for Patient and Family-Centered Care first supported us in expanding our services related to patient and family engagement. They started with our 11 family medicine practices in-state, and the results we saw from this work were amazing. We've rapidly expanded this work both locally and nationally with our clients. Since 2012, we've been actively working with 60 practices in the Comprehensive Primary Care Initiative to expand their patient engagement strategies in a blended model. 80% of those practices have done so and mark it as one of the most valuable aspects of their transformation efforts. The objectives of today's webinar are to define patient engagement in both practice and system level quality improvement efforts, identify 3 ways to engage patients in quality improvement efforts to achieve a blended model, and learn from a case study about what benefits and lessons learned have been achieved by a large multi-specialty medical group in their transformation efforts. Meaningful patient engagement activity is not a check-the-box activity or a milestone to achieve. Rather, it's a path toward creating a different level of partnership with patients and families that drives shared value, trust, respect, and improved outcomes of transformation efforts. I'm going to take you through HealthTeamWorks' experience from an outside perspective with different models and the value of the balance of quantitative data and qualitative data collection methods. Dan will talk to you about his experience with expanding into a blended model approach to patient engagement at Cigna Medical Group in Phoenix, Arizona. What we won't do during this webinar is do a deep dive into all the tools and resources there are to support you in this endeavor. We know that the Institute for Patient and Family-Centered Care is actively involved with your practices, and all of their tools and resources are available at their website, www.ipfcc.org. So what we have found in our 5 or so years of experience in engaging patients meaningfully in quality improvement is that it prioritizes and accelerates meaningful change activities. It builds strong relationships with patients in the community. It provides real-time qualitative data to support change efforts. And it creates a shared vision between patients, staff, and leadership. There are 4 methods that we're going to talk through today. The first are patient experience surveys. The second are the use of patient focus groups. The third is using patient and family advisory councils. And the fourth is integration to the quality improvement team. The fifth is really a blended model of one or more of these methods. So just to describe briefly what each of these are, patient experience surveys are pretty self-explanatory. They're regular surveys out to patients about their experience. Focus groups are occasional groups that happen with patients to get their feedback. Patient and family advisory groups or councils happen regularly with the same group of people. And integration into the quality improvement teams mean that patients regularly attend the quality improvement team to give feedback and are seen as part of the quality improvement team. Mixed methods are one or more of these combined. So we're going to do a quick poll that we're hoping you can respond to. Which method does your practice do now, or does the system do for practices? If you could please select all that apply. Okay, great. So based on your results, 72% of you are doing surveys, 19% are doing focus groups, 26% are doing patient and family advisory groups or councils, 14% are doing integration into the quality improvement team, and 26% of you are doing mixed methods. That's great. Thank you for your response, and that'll help me know where to focus our time together today. So surveys, we're not going to spend a lot of time on this since the majority of you are already doing surveys. So clearly you probably understand the benefits. So for us as quality improvement and transformation experts, we always are in support of quantitative data. It helps you prioritize your change efforts and it helps you track those changes over time. It also provides a specific answer to questions when you can modify your survey to get feedback on something specific that you're trying to transform. Finally, it can generate ideas to bring back to the other methods like focus groups or patient advisory councils so that you can get more qualitative data. Some of our recommendations from our experience is that in order to be able to track your data meaningfully over time, it's very helpful not to change the questions on every survey. So generally, we make the recommendation to have a standard set of patient experience questions to which you can add variable questions about specific issues that you need feedback on. Also, survey on a regular schedule, so whether that's monthly, quarterly, biannually, or annually, making sure that you follow that schedule, and ideally no more than 20 questions. I know surveys like CAPS or others have more questions than that and are sometimes required, but if you're creating your own survey or using one that you can customize, the simpler the better for a better response rate. And then finally, we feel that a survey that evaluates the experiences of a patient experience really should have a minimum of 4 topics. And those 4 topic areas are patient access, patient communication, care coordination, and whole person care and self-management support. So patient focus groups, I'm going to spend a little time on this. Dan's going to give you quite a bit of his experience in doing focus groups, so I'm not going to spend a great deal of time on that. But basically, patient focus groups happen at irregular intervals, and they're composed of individuals for their point of view on a single topic. So when you send out your patient surveys and you're getting specific issues around access or patient communication, but you can't quite get enough information within the survey to drill down to what the actual issue is, you can bring that to a patient focus group. Another great way to use a focus group is when you have gone through an assessment of a need for improvement and you have some ideas ahead of the launch, which Dan will talk a lot about. You can pull your focus group together to get their feedback before you try to launch the transformation effort. In general, we recommend that a focus group only have 6 to 12 members, similar to a quality improvement team. Less than 6 doesn't provide meaningful representation of your patient population, and over 12 members can create too large of a group to have everyone share and discuss things. Generally, a focus group is facilitated to elicit perceptions, feelings, attitudes, and ideas. So asking questions like, if you waved a magic wand, what would you change about access? So asking very open-ended questions, trying to get a balance between how they feel about an issue, their actual experience, and then their ideas on ways to make changes to support patients. So we recommend that patient focus groups don't happen too often, that they're really used strategically throughout the year so that you're not running focus groups too regularly. It's important to either have an experienced facilitator or a facilitator who's received some level of training on facilitation so that they know how to balance group dynamics and get people engaged in talking. And similar to the Patient and Family Advisory Council, it's always helpful to invite 5 times or more the number of desired participants so that you get enough confirmations and attendance to make the group meaningful. And finally, we recommend that you keep them to 1 to 2 hours, not much less or not much more. So the Patient and Family Advisory Councils are by far the most extensive work we've done, both with the residency practices we work with in state, as well as the Comprehensive Primary Care Initiative practices that we have in state. So the Patient and Family Advisory Counselor group is very similar to a focus group, except that it happens on a regular interval with the same amount of people for a certain amount of time. So you get a group together, you recruit, you interview, and you have your council, and you set a regular schedule, whether, again, it's monthly, quarterly, biannually, or annually. You're bringing that same group of people together for an amount of time to try to get their feedback. The great thing about the council is that it brings people together in a trusting environment, and they stay together through a period of time. So it really provides that opportunity for staff to have a safe venue for patients to express their needs and concerns when the council is facilitated well. It also really facilitates and promotes respectful, effective partnerships between the practice, its patients, and the surrounding community, and gets you much richer and more meaningful qualitative feedback to support your quantitative data in your surveys. It also offers a forum for developing creative, cost-effective solutions to problems and challenges. So often patients can come up with ideas that as a practice representative doesn't come to your mind, and so they can come up with simple ideas that are more cost-effective than we might by facilitating the group without them. So I'm not going to go in detail, as I said before, into a lot of the tools and specific recommendations because the Institute has all of those on their website. But from our experience, whether you're recruiting for a focus group, a patient and family advisory council, or to get members onto your quality improvement team, it's always helpful to have a champion. So somebody who really has good relationships with patients, is passionate about patient engagement, and having that champion really help create a recruitment strategy. So whether that's talking to providers and staff about who they think would be best representatives, whether it's sending out, in some of our smallest practices in the rural area, it's sometimes even been posting advertisements in the newspaper. It can be a newsletter out to patients. It can be posters in the waiting room. But basically creating a recruitment strategy that really works for your specific practice or system within your context. And then also on the website are interview templates and ideas and ways to interview patients. Sometimes it's very easy to think about patients that really like our practice and have long-standing relationships with the practice, and that's really great. But we also want patients who are comfortable voicing concerns they've had or have had complaints in the past, and they've expressed those in reasonable and positive ways so that you have a balance of participants. Also thinking about diversifying the members of your panel, so whether that's by age or race or gender, really thinking about your patient population and pulling some of those demographics to make sure that you're representing your patient population. There's also a coaching and sort of preparing of patients. When we first launched into this in 2011, with the residency practices, we were recruiting and we were helping them recruit, and we were getting people onto councils and in focus groups, and we sort of overlooked, despite the Institutes for Patient and Family-Centered Care, their advice to really coach patients and prepare them. We sort of overlooked that step, and patients sort of came into these first meetings with deer in the headlights look and really not knowing what's going to be expected of them. So whether it's that champion at the practice level or somebody else from the quality improvement team, it's really coaching those patients about what to expect, what their role is, what a quality improvement team is, what the intention is before the patients arrive at their first meetings. Then, as I mentioned earlier, it's really important to be intentional about how you plan to facilitate those meetings, how the agenda will look, who will be the main facilitator. It can often be very intimidating for patients to be the only person on a council, especially when the council could be 8 people or more. And so it's important to think about how many patients you have at the meeting versus how many practice staff. And so you really want to be thinking, what's the balance and what's the most comfortable environment for patients, and how will we facilitate them comfortably into the meeting? And then, again, a lot of the value of the councils or the quality improvement teams or the focus groups is really your ability to provide topics that are meaningful to you about your improvement efforts. It's also helpful to allow them to develop projects that aren't even on your radar yet, but that could really benefit your outcomes from both a patient experience, cost, or quality perspective. And I'm going to give you some of those examples at the end of my presentation here. And then at the bottom, you'll see consider term limits here. So sometimes patients get onto councils or quality improvement teams, and at the end of a certain amount of time, the practice really feels like they could use new input and new energy and new perspectives. And if you're not thinking about the term limits ahead, people can be easily offended when they're asked to step down from that position. So we learned some key lessons about within that relationship and how you define it within the charter, and in recruiting patients, communicating term limits to them that can always be extended, but that are communicated ahead of time. And then finally, I would say the most advanced patient and family advisory council, or maybe what can feel most risky, is sort of integrating one or more patients into your quality improvement team in an ongoing way. So the nice thing about involving them directly in your quality improvement team is it gives you real-time patient input on a very regular basis. And it doesn't necessitate your need to create more resources and time outside of your existing meetings to have another forum in which patients provide you feedback. You can get that feedback right away within the infrastructure you already have. It facilitates a lot of trust and transparency with the patients. And I know when we first started this with most of our practices, they really felt like they had to get things in order before they let the patients in. So they had fears about patient struggles or where the practice was getting negative feedback. And there was this feeling of need to fix things before patients came in. And I'll give you some examples of that in a few minutes. But our experience is exactly the opposite, that bringing patients in the more immediate future to help you fix problems will help you facilitate a faster process to improvement versus creating a whole structure that isn't meaningful to patients and you find out too late. And again, similar to the council, it offers a forum for developing those cost-effective solutions you wouldn't think of yourself. I'm not going to go through these again because they're really the same as the Patient Family Advisory Council. And again, those tools are really helpful that you can find on the website. So before I turn over to Dan, I just want to give you one example from my experience, and there's literally tens, if not hundreds, of examples of why this is such a meaningful activity for your practice transformation efforts. One example, I was working with a residency practice early on, and they were really feeling like they didn't want to back to my point earlier, they didn't want to bring practices on the team or involve them in their quality improvement team efforts until they had things better defined. And so one of their main points of transformation was on their chronic disease management of diabetes. And so they created this whole really creative and interesting new approach to chronic disease management for patients with diabetes. It included a passport, and they got stamps for different levels of activities and different role definitions and moving staff to different levels of licensure and things like that. And they created this whole program, and then they invited, they sort of launched their Patient and Family Advisory Council using this, this whole transformation effort as an example and something that they felt comfortable with taking to the council. And so they got their council going, and they came and they did this wonderful presentation on why they created the program and the data and what they were hoping to achieve. And the patients just sort of sat there blank-faced, and one of the patients sort of captured the feeling in the room, which is, you know, I really think about a passport as something that I go and purchase to go do something fun, and diabetes really isn't fun, and so there's a disconnect for me between a passport and my activity in the practice. And so, you know, a lot had to be undone at that point. There was general agreement among the patients with diabetes who were at that council meeting. So that's just one example of where the practice sort of had to back up and rethink their strategy versus getting the patients involved earlier. Finally, I just want to talk about some creative ways once practices and systems have gotten really comfortable with and have seen the results of integrating patients and families into their quality improvement efforts. I just wanted to give you a couple of examples of ways that they've expanded that. One is using patients and staff orientation and training. So I worked with a practice in California that was embedded within a system, and they had such engaged patients that made such amazing changes in their practice that the system took note of it at the inpatient level, and the leadership there started integrating those patients into staff orientation videos, helping them construct training, and actually attending orientation sessions. We've had our in-state practices bring patients who've been involved in their quality improvement activities for a while to our learning sessions. So they come as a practice member to our learning collaboratives or learning sessions. And we, as HealthTeamWorks in our practices and systems, have also started using patients as presenters in our learning sessions. So I feel like once the process starts and it's going well and the value is immediately seen, there's endless ways that you can engage patients. And finally, I want to say that I brought Dan in because of his passion of patient engagement and all the great things that they did while I was working with them and since then. But I want to emphasize that whether you're a small practice in a rural area to an urban multi-specialty practice to a practice embedded in a system that has resources to support you, there is a strategy that will work for you based on your resources and time, size of your practice and population. And that's been true of us, of all of our practices. They're very diverse, and that yet they've found the equal value and the equal outcomes from embedding this practice into their transformation efforts. So with that, I'll turn it over to Dan.
Great. Thank you, Nicole, and thank you all for attending this webinar. I'm excited to share with you how Cigna Medical Group has engaged its customers to drive process and cultural changes at its clinics. I would like to get a sense for who's participating in today's audience, so please respond to the poll question that appears on your screen. While you do that, as a quick introduction, my name is Daniel Zaraxide, and I am the Director of Clinical Operating Effectiveness at Cigna Medical Group. My department drives strategic projects and utilizes project management, process engineering, and change management to make sure we implement the right solution on time and that we sustain that change over time. Before I dive into the presentation, I'd like to share with you a story regarding my first experience running a project that targeted customer experience in the healthcare industry. I joined Cigna a little over 3 years ago to work on a project that focused on improved customer experience at Cigna Medical Group's clinics, which are located in Phoenix, Arizona. I was thrilled to join. You see, I spent my previous 7 years running projects in the property casualty insurance industry, that improved things like cycle time and quality and staff satisfaction. This would be my very first time directly impacting a business's end customers, in this case, Cigna Medical Group's patients. I flew into Phoenix from Connecticut in April of 2013 for my first experience at Cigna Medical Group clinics. After the official project kickoff, I wasted no time to go to a clinic and shadow patients. I got to experience Cigna Medical Group's patients' journeys through their primary care visit, and I was amazed by the care the patients received. In fact, when I arrived back in Connecticut, I told my wife, Kat, that I wished our doctors were as good as the ones I saw in Phoenix. I worked with the rest of the project team to gather and analyze existing customer survey data, gathered and understood process data to find out what was driving patients' wait time, which is, as I'm sure we all know, a critical success factor in patient satisfaction, and also determined what solutions would make the biggest impact on our patients' experiences. We decided to pilot our changes in one site in Southeast Phoenix to determine which improvements truly work. The project team met in Phoenix and created, distributed, and collected customer surveys that were handed out at every visit. I diligently and anxiously entered the data into my workbook, anticipating a meteoric rise in customer satisfaction. When the final record was entered, and there were approximately 600 records, I set up my formula to tell me what our new improved customer experience score was. And it hadn't moved at all. I sat very frustrated on the plane headed back to Connecticut. We did everything: patient shadowing, survey analysis, process improvement to reduce wait time, and we did prove it was reduced. We spent time in conference rooms brainstorming solutions that would make us delighted as customers, then identified the ones that would delight us the most and implemented them. Quite honestly, I felt like a failure. I felt like I should have never taken on this new job. So when I arrived home, my wife, Kat, greeted me with a smile. I thought I smiled back, and if I did, Kat knew it was not sincere. She asked me what was wrong and probably wondered if I was not happy to be home. I answered in my generally terse manner, work. Kat asked me to tell her more than just work, so I did. I told her that the project team had performed a ton of work and felt that we had the right ideas. I told her how I stayed up until midnight entering all those different customer survey data just to find out that nothing changed. I told her about how I worked with the project team in a conference room to brainstorm ideas that would delight us as customers. That's when Kat interrupted me. Wait, she said, you and the team spent time locked up in a room figuring out what would delight you? Yes, I responded, not realizing I had just put myself into a checkmate position. Kat wisely responded, you are not the customers. The following week, I was back on the plane to Phoenix. Frustration was now replaced with enthusiasm. I arrived at the Phoenix office and declared that we would be conducting a patient focus group. We all agreed that it does not matter what would delight us, but what would delight our customers. The project team loved the pitch, and we conducted our first focus group a few days later. We had approximately 20 customers come to the focus group, and all were eager to share their experiences. At first, we heard many ideas that we tried as part of our pilot, but then something happened. People started mentioning little things like having vacancy indicators on bathroom doors, having doors that weren't so difficult to open or that did not slam on the back of their wheelchairs as they tried to enter the rooms, educational materials regarding their high blood pressure that they could read between getting their vitals taken and when the doctor arrives in the exam room. These were all new ideas to us, and they were very specific to the center we were piloting. We quickly implemented the changes, distributed the surveys, collected them, and I analyzed the results. The needle was actually moving now, and in the right direction. The project team was excited again. We felt we found the secret sauce to site-specific improvement. These focus groups became a way for us to continuously identify incremental and impactful change. And most of those improvements were very easy to implement. Needless to say, when I got back to Connecticut, I greeted my wife with a very big and very sincere smile. In this presentation, I'll provide you with a case example of how Cigna Medical Group partnered with its customers to implement a new team-based care model at one of our centers. Now, this is a different project than the one I mentioned earlier. This is one that was pretty recent and one that I partnered with Nicole on. I did not get a chance to see the results of the polling question. If it's possible to bring that back up, that would be fantastic. If not, there we go. So we have many other, several providers, several supervisors, and some folks from mid-levels and back office staff. Okay, so I'll keep this pretty general so that we make sure that we target the needs of everyone who is attending today. Today I will provide you with an overview of the Cigna Medical Group, who we are and who our patients are, a brief history of how CMG engages its patients to drive change, spend a majority of time talking about Cigna Medical Group engaging patients in our team-based care effort that I mentioned already, and highlight additional projects that leverage informal focus groups to gain insights for continued improvement. Chances are that if you live outside of Phoenix, you have not heard of Cigna Medical Group. Cigna Medical Group is a primary care-based multi-specialty medical group and consists of 20 centers across the Valley of the Sun. In addition to the services above, Cigna Medical Group has 3 and soon to be 4 urgent care centers. Our providers and clinic staff are employees of Cigna and provide incredible customer experience. In fact, our Net Promoter Score hovers closely around the 78% mark, very strong. Our notably high Net Promoter Score is a result of the individuals we hire and also our understanding of our customers' needs and acting upon those insights. This slide provides a high-level view of Cigna Medical Group's journey of customer insight gathering. Cigna Medical Group has been using formal surveying for many years to understand customers' needs and experiences. These surveys include questions targeting critical moments in the customer's visit. These critical moments can include, and are not limited to, experiences during the check-in process, as they're being roomed in vitals, the examination itself, and the discharge. This is also where we are able to capture our overall Net Promoter Score. Traditionally, we have used the survey responses to gain insight into what changes we can implement across all of our 20 centers to further improve our customers' experiences. These are not really site-specific improvements. We've also leveraged professional focus groups. These are led by hired facilitators and let us gain insight into specific customer groups, for example, our Medicare Advantage population. By diving deep into these particular customer groups, we're able to understand opportunities specific to that group and take action based off that. Over the past couple of years, Cigna Medical Group has used informal patient focus groups in addition to the surveys and professional focus groups. These focus groups provide insights regarding experiences at specific clinics and often uncover quick-hit opportunities like the ones I mentioned in my story. This also could include things like rearranging furniture in the waiting room to make it easier for people to navigate with their walker or their wheelchair. In a moment, I'll discuss how we utilize these informal focus groups to guide our implementation of team-based care at one of our clinics. Currently, we are exploring the opportunity to engage patients as part of our clinic-based continuous quality improvement program. This is similar to what Nicole had mentioned earlier. The benefit we anticipate is that we can immediately receive patient feedback on different improvement opportunities and also on concerns, considerations with the solutions that we're proposing. And lastly, for feedback on the solutions that we've actually had a chance to test. Cigna Medical Group recently implemented a team-based care model at its clinics. The goal of this effort was to create a new way of engaging our patients during their visits. This ultimately included adding new services, most notably having clinical pharmacist visits and behavioral health visits, as well as reconfiguring the staff in the back office so that they're more of a team formation and redistributing their workloads. You will see several benefits of this team-based care model listed on the slide. We were able to increase our physicians' panel sizes and allow back office staff to work at the top of their licenses. Our patients' experiences were improved, as they were receiving even more focused care from the clinicians. Patients were leaving their visits with a more thorough understanding of their care plans, which resulted in increased adherence and greater health outcomes. Lastly, our staff expressed increased satisfaction as they were more empowered and were actually working to the top of their license. That is, doing what they went to school to do, and were working even as a stronger team. Cigna Medical Group staff, including providers, front and back office staff, managers, and leaders, collaborated to create a prototype of the team-based care model and outlined a new journey for our patients. We wanted to study the model at one of our centers and validate what worked and did not work, and continuously refine the model to be as impactful as possible. Since the proposed model was to benefit our patients, we decided to hold patient focus groups to understand the customer's opinions of how the process is working and get feedback on our proposed model. We conducted a pre-study focus group to accomplish that. We also knew that we would want patient feedback during the study itself, which we would use to refine the model. We also wanted to receive some success stories, which would be used to increase energy and enthusiasm around this new team-based care model within Cigna Medical Group staff. We chose to hold this focus group approximately 2 months after the original. It really allowed our focus group patients to have their visits in the new future state, I should say. It also allowed staff to become more proficient with the processes so the patients will really experience the process as it was being performed by very proficient staff. We obtained valuable and actionable insights from both focus group sessions. Now, I do want to make a quick note. We did not have a post-study focus group specific to team-based care. In fact, we utilized that same focus group participants and in a few more for another initiatives focus group, and we spent a little bit of time during that other initiatives focus group really discussing the results of the team-based care study, and also gave us an opportunity to thank them for their input. At this time, I want to pause just for a quick poll on how folks have used informal focus groups. So what I'm looking to see is what your experience is with leading these focus groups. Perhaps you've led one or more. Maybe you've never led one and you're excited to conduct one, or you've never led one and are nervous to conduct one. Great. So it looks like we have several folks, 40%, who have led one or more focus groups. That's great. Always wonderful to see. Nearly the same, 34%, saying that they've led focus groups and are very one. That's also wonderful. And I see a few people who have never led focus groups and are a bit nervous to conduct one. So that's great. What I'm going to be presenting in the next few slides are kind of how we approached it, and that will help folks perhaps who have done this before. Perhaps there's some new things here that you can try out. And also for those who perhaps are nervous or you're going to have your first focus group coming up, give you a few tricks of the trade, so to speak, some lessons learned from our experience here at Cigna Medical Group. Thank you for participating in that poll. For the pre-focus group, I'm going to spend some time describing what we did before, during, and after this focus group. This information may help you as you prepare to conduct focus groups of your own. I worked with clinic staff to identify participants for the focus groups. So it wasn't me randomly selecting folks, it was actually the staff on site. And we wanted to make sure that collectively they represented the patient population of that specific center. So staff made sure we had participants of different ages, genders, cultural backgrounds, as well as patients with different healthcare needs. We invited patients until we had 20 who said they would be able to attend. We did that knowing that several would cancel by the time the focus group actually took place. The session was held after business hours, so we were sure to provide dinner, dessert, and drinks. And lastly, I requested that our senior leadership team attend this first session, which excited the patients when they arrived and also increased sponsor and stakeholder engagement. The session lasts 1.5 hours. 12 customers of the 20 that had accepted were actually able to make it, and I was hoping for a minimum of 10, between 10 and 15. This was our very first focus group with these patients, and so it was really important for us to develop a relationship and connection, as well as educate the patients on what we were aiming to accomplish. To do that, after having each participant and Cigna Medical employee introduce themselves with a typical name and something about their background, I kicked off the session with a personal story that was relevant to the project. In this case, it was when I was in middle school, and in 5th grade, we were kind of instructed from the teachers to take our math book home with us and complete our homework. And by the time that I was in 8th grade, things had changed so much that now there was this almost team of folks who you could reach out to for help for those math problems. The local grocery store had a homework hotline that you could call for assistance. We now had mathematics tutors who were available after school and during kind of what was called X block or study hall. So kind of related that to the team-based care model, and this really immediately engaged the patients and formed a close bond with them. The majority of the time was really spent gathering information on our patients' experience today, and also collecting feedback from the patients on the future state model. So we actually took some of the different things that we were proposing, got their feedback on it, and allowed us to make some tweaks to that before actually implementing our pilot. We also got some quick hit feedback that was outside of the team-based care model that allowed us to make small but meaningful changes within the clinic almost immediately. There was one comment that stood out as well, and that was, if it ain't broke, don't fix it. Really telling us, why are you even bothering? So I'll get back to that comment in a moment. What you'll see here is, again, we identified some of those delighters that we could integrate into the team-based care model. We developed these really strong new relationships with these customers, and the sponsorship and stakeholder engagement went through the roof, which helped us as we pursued this project further and needed to overcome some obstacles that only our sponsors and stakeholders could help us overcome. Our study Midpoint focus group involved the same participants. So these are the same individuals that attended the first one. And again, we provided dinner, dessert, drinks. This time, senior leadership did not attend. They were very engaged in the project. They simply had other conflicts for this particular session. The participants were extremely excited about the second session. They really wanted to come back and share some more insights. And they did share some additional ideas for further improvement. We also got some terrific testimonials, which assisted with our overall change management effort. All the patients had positive feedback on the team-based care model. In fact, one of the participants said, "I know I said last time, if it ain't broke, don't fix it." Well, I was wrong. This new model is amazing. Ultimately, the patient's input allowed us to achieve the business results I mentioned earlier. That is, we were able to increase our physicians' panel sizes and allow back office staff to work at the top of their licenses. We increased our patients' experiences during their visits. Patients left their visits with a more thorough understanding of their care plans, which resulted in that increased adherence and greater health outcomes. And our staff expressed increased satisfaction as they were even more empowered and again, working towards the top of their licenses. Our customers loved being part of the focus group. They were even more engaged than before, and we found that they were advertising to our clinic to friends and neighbors. When they came to the office for their visits, they would often ask when the next focus group would actually occur. Some were even nervous that maybe they got kicked off the focus group. A critical success factor was actually taking action based on the ideas submitted in the focus group, especially if we promised to make certain changes. There were many of those quick hit opportunities that we said, oh yeah, we can absolutely do that. If we had not taken action based off of that, we would have lost these customers from an engagement standpoint, and they really wouldn't have trusted the focus group process. So I do want to take a pause for a quick poll on projects that you may have that could benefit from patient focus groups. So do you have any projects or initiatives that could benefit from utilizing patient focus groups?
And feel free to add those programs into the chat box so that we can kind of get an idea of what everyone is doing.
Perfect. So I was hoping to see a high number. It would have been a very uncomfortable rest of the presentation if it were a low number. So what I would like to do, I see lots of yeses, so that's fantastic. For those of you who have a no, what I would like to do is share a few projects that we've used this for. And what I've found more and more is that pretty much any project you have, there's an opportunity to somehow engage your patients. And perhaps focus groups aren't the way to do that. Perhaps you can use one of those different methods that Nicole had mentioned earlier. So that's completely fine too. What I would just like to see is folks really proactively reaching out to patients to get that more in-person sense of what their needs are, but still utilizing things like surveys. So let me round out this portion of the presentation with what we're doing here at Cigna Medical Group. I'm not seeing the presentation come back up, so I'll just speak to it for now. So we have at least 4 projects going on right now that are utilizing patient focus groups. One is community engagement, and the purpose of the community engagement project was to partner with and connect our patients to available community resources to better support their total health and well-being. During the focus group, we discovered that patients were very open to connections with community resources, especially provided if they're offered at the right price, which is generally for free. And individuals said that they had ideas for additional resources and events that we weren't aware of. So we gained a lot of information about new community resources that we could utilize and really engage our patients in a new way. And then we're also made aware of some barriers to our patients using these community resources, such as the cost of them or lack of transportation. So now we knew about some new obstacles that we'd need to overcome for this to be successful. And we would not have known this without engaging our patients. The patient self-service project targets allowing patients to fill out, submit forms, and other items electronically ahead of their visits. The insights here allowed us to understand many of the privacy and security concerns felt by the customers. And these are items that, again, we hadn't thought of prior. The quality of service project focuses on capturing our customers' concerns while they're there in the clinic and really taking action quickly based on those concerns. And the customer insights there shone light into requirements for following up with our customers regarding their concerns, number of days, how quickly we need to make our changes and acknowledge and react to whatever those concerns are. And the Service First project really focused on delighting our customers, taking that experience to the next level. And these customer insights identified some of those different delighters that would improve our customers' experiences and loyalty and kind of word-of-mouth promotion. So those are just 4 projects in addition to the one that I already spoke of that we're utilizing these for. Again, I kind of have the mindset that just about anything we do has an impact on our patients. So as much as we can involve them and get their insights, the more successful those projects will be. So I encourage you all to look at the different projects you're running and identify opportunities to engage patients in person and beyond surveys to get those critical insights that will allow your efforts to succeed. So thank you. I'll turn this over now to Nicole to round out the presentation.
Thanks so much, Dan. I find you inspiring as always. So one quick final poll. Thanks so much for your participation during the webinar. Could you guys take this final poll about, I know you already answered about which ones you're already using. I'm interested in hearing, and I think Dan and I are interested in hearing about which new patient engagement method or methods you are considering now that you've heard the presentation. So if you could respond to that poll, that would be great. Okay, so many of you were doing surveys already that I see some of you have added. That's great. And it looks like people are interested in adding focus groups, patient family advisory councils, and integration to the QI team and mixed methods. So that's great. So it sounds like we hope we met our intended objectives. With that, I know I've seen a few questions come across the chat, and there may be others. So I just want to say to everyone, thank you so much for your participation. We will be available in the office hours over the next half an hour after this presentation, but feel free to add in your questions into the chat. Jacinta, should I answer the one that I saw directed to myself? And Dan could probably answer this too, about how patient and family advisory councils connect practices to community organizations and resources. Would that be appropriate now?
Oh yes, that'll be great. Thank you.
Okay, great. So Dan may be able to speak to this too, and I think it's a really great question because it's not a direct line or obvious. So thank you for asking that question. So the way that I've seen practices and systems become more connected through the community, through those groups, are that when you're talking about chronic disease management or mental and behavioral health management or other issues that come up for patients, those healthcare experiences they have at your practice or within your system generally aren't isolated to that experience. It also has to do with the referrals you make or don't make, other community organizations they may be involved with that aren't on your radar. So some of the ways that I've seen practices become much better connected with their community is in knowing about and connecting with mental health and substance abuse services they may not have been aware of. Even including AA and Al-Anon meetings, Alcoholics Anonymous and Al-Anon meetings, things like aging services. All the aging services are kept up to date in the AAA workbooks and things like that, so they'll often hear about transportation or exercise or other services available that they might not have been aware of. And finally, one of the biggest values that I've seen when patients feel safe in that ongoing group or council is that they'll start telling you honest feedback about their experience to to whom you're referring. So whether it be a specialist or a hospital or some other type of provider, practices have gained a lot of insight about who they should be referring to and who they're not currently, and even more importantly, who they're referring to that patients are having negative experiences with that would naturally come out within a survey. So I would say that's one clear way that I've seen the practice relationship with the community change. Dan, I don't know if you have any other examples.
Yeah, and thanks, Nicole. I think you really covered it all. So the only addition I'll have is I mentioned that community engagement project that benefited from having the focus group, and as Nicole said, one of the benefits was for us to help educate those particular patients about what's available. But the other thing that was really enlightening for us is there were plenty of resources that we didn't know about, that the patients knew about because they have it on their, maybe it's on their senior center bulletin board or whatever it is. And so we found new ways that we could engage our patients and connect them with some of the different community resources. So that was really helpful for us. The other one was around obstacles that were preventing folks from being able to actually get to those community resources. And so I mentioned things like price and transportation. So that allowed us to kind of focus in on some pretty critical obstacles that without overcoming those, our patients, even if they're aware of these different community resources, really wouldn't be taking advantage of them and getting some value from them.
So Dan, I see another question here directed towards you. Could you discuss your opinion about paying or incentivizing patients to engage in surveys, focus groups, advisory boards, et cetera? What are the pros and cons?
Sure. So, I'm in the Cigna Medical Group, I should say, is in a really interesting position wherein we are both the payer and the provider. So the reason why that puts us in an interesting position is because if we were to incentivize too much, then it might be thought of as a perk of their healthcare plan, and then consequently get us in a little bit of trouble. So we chose not to really formal incentives other than dinner, dessert, drinks, like I mentioned earlier. What we found actually was that patients were really delighted and excited to come to these just because, one, they get to interact with other patients and share experiences, and then two, again, as long as you're taking action based off of that, they feel even more involved in the, as part of a larger Cigna Medical Group family, and that was a huge incentive in itself. Now that being said, as focus groups closed off because they were usually initiative specific, oftentimes the operations leader for that center would send out a thank you, and there might be like a gift card or something like that in it, but it was not expected by the patient. I think there are many pros and cons to outside of Cigna Medical Group to utilize incentives. My opinion, just based off of the experience, is that they may not be necessary. The other thing is it could influence the outcome of that survey. So if they know that they're getting $10 to fill out a survey about their provider, they may be more likely to put in a more positive thing, knowing that they might be getting $10 than if they weren't. So my vote would be start out with not incentivizing, but really promising those actions you're going to take and following through with those, and then really kind of thanking folks afterwards and maybe providing that gift card if you feel like that would be an appropriate thank you. Nicole, I'd be curious to get your thoughts based off of your experience as well.
Dan, it's Nicole, and I couldn't agree more with everything you said. I think in general it's a best practice not to start with financial incentives, but with those incentives of participation, food, and other sort of peripheral things. I also agree that if people have spent an extensive amount of time and provided a high level of value, you could always make the choice later to incentivize them in some way, but starting with that sort of sets a precedent that you may not be able to see through, and as Dan said, might motivate people in the ways you don't necessarily want to motivate them. I have another question, Dan, that I'll try to answer first, and I'd love to hear. So from you, one of the questions is, did you get an IRB for the focus groups? And I'm glad this question came up because I did forget to mention something. For both the Patient Family Advisory Council and the Quality Improvement Team, we highly suggest that you have patient advisors sign HIPAA forms, because often other patient names will come up during those sessions when discussing certain issues within the quality improvement team, or they may hear something in the hallway that they wouldn't normally be privy to. I have not had the experience in any of the practices we've worked in, nor the residencies, of pursuing IRB. Have you, Dan?
No, we have worked with our compliance folks here at Cigna Medical Group to draft and utilize a form that essentially is a confidentiality agreement, and that's been as far as we have needed to go. We do make it very clear during the session that, you know, the room's kind of like Vegas, and what happens there stays there, and not to share beyond that focus group.
So with that, Jacinta, I don't see any more questions. I know we have about a minute left.
Yeah, we don't have any more questions, but we did have a follow-up from the community-based organization question. They were curious to know how practices navigate the barriers of cost or transportation once they are aware of them from the patients and families. They're not sure if this is kind of outside the scope of practice, but just curious to know if that is something that you guys have come across.
So let me say back to you the question, Jacinta. So it's really about, once you've identified barriers, how do you address them? Am I saying it correctly?
Right. Yeah, barriers
Okay.
like cost or transportation. Yeah, once you get that feedback from the patients and families. Yeah.
That's a great question. So I'll answer it from my perspective. So practices and systems have varying levels of resources, as we know. Some have a care manager assigned to their practice. Some have some level of care management. Sometimes people don't have anyone outside of the visit staff. And so the model that you would choose to address those barriers with patients would most likely be based on your population, your resources. Some of the ways that I've seen practices do that with little resources is by creating resource sheets. So by age or issue, when they become more aware and they become more proficient at chronic disease management or mental health support or things like that, they develop resource sheets that they can use across their patient population versus trying to do it in a non-standardized patient-by-patient way. And Dan, with the few seconds we have left, do you have anything to add to that one?
Sure. So here at Cigna Medical Group, again, one of the issues around it is that if we pay for folks' transportation, as an example, it could be interpreted as a benefit of their plan, and that gets, again, gets a little dicey. What I have seen other institutions do is some of them have existing shuttles that, for example, will pick up patients from their home or from their care facility and bring them into the clinics. I've seen them leverage those shuttles to also transport folks from either the clinic or from their home again to whatever that community resource is at no cost or for a really minimal fee. So that's how I've seen some other groups find ways to overcome that particular obstacle.
And it's sort of a broad question, so we can dig deeper probably in the office hours as we transition over to that if the person who's asking wants to stay on.
Yeah, that would be great. And so, yeah, as Nicole said, we are at the top of the hour. So I would like to thank everyone for attending and being so engaged in today's presentation. So again, the slides and the archived recording will be available on our website, and that link was provided in the chat earlier in the presentation, and that will be posted within the next 24 hours. So feel free to drop off right now if you'd like at this point, but we will continue with our question and answering during our office hours session. So thank you everyone for attending, and thank you Nicole and Dan for your very interesting and engaging presentation.